We'll be starting the first session. As traditionally, we always started this session with a sort of exam-related topic. So this year, again, Dr. Singh will be talking about tackling the clinical exam. Professor Singh.
A very good morning. I remember my PG days, and including the MBBS days, a couple of months before the exam, our seniors asked us, "How are you?" I said, "Terrible." He said, "That's very good that you will pass." I said, "How come?" Those who don't feel terrible or they are not scared, they don't pass. So always be scared. So we'll be talking about in the beginning how to pass the exams, because the preparation starts from the beginning. And we all know that the purpose of the examination is to be a consultant, and you will be working independently, and you won't have anybody to turn to in case when you pass your exam. We will talk about how to prepare, at the same time how to appear in the examination. So naturally for preparation you have to work into the depth of every topic and the width of the subjects. And unless we examine patients and present those cases, we won't know what is important in understanding that. Rational thinking. And I asked Gemini how to prepare the exam, and this is what Gemini told me. I normally imagine when we are preparing that how we start when we enroll into MD. It's very obvious that we have to understand how to examine the patient so that we get to know what is wrong with the patient and what are the good things we can use ultimately to make the person be rehabilitated. And unless it's very hard to understand what we see in the patients, because the mind, eyes don't see what the mind doesn't know. And I say carry on reading from page 1 to the last page of the textbook, Bradham, DeLisa, whatever you like to. And then whatever patient that you see, go and read about the patients, differential diagnosis, the management. And whatever classes are assigned to you and the seminars which are assigned to you, you naturally study and keep the notes, and you will remember that forever. And it is very good to teach others in their classes or your fellow students who can divide your topics, and also practice the questions which are asked by the faculty. And naturally revise from time to time to have the long-term memory come onto you. In addition to your regular books, read the books on these topics. Of course, these are not the limited ones. And of course, you have to prepare for the Viva. And for the Viva, you have to read additionally about prosthetics and orthotics, the x-rays, the ultrasonic examination, MRIs, and of course you have to practice it every day in your patients. And what are the interventions, what are the drugs used for the interventions, the electromyography, etc. These are not limited things, they're just giving you the where we are at the moment, and that used to help prepare the student how to write and how to present the examinations. In the case presentations, like for the case presentation, when you are presenting, when you are preparing, you have to practice the history, physical examination, of course, and present it to the faculty, peers, or your senior residents. But always remember, try to have head-to-toe approach. See everything of the patient. I'll come to this, and what mistakes are made in this, and you have to familiarize yourself with the common cases that come to the OPD or are admitted in the ward. These are the ones which will be asked to you. And when you see the patient, justify the clinical reasoning of their diagnosis and the differential diagnosis and the management. And I summarize how frequently the postgraduate should present the cases. Initially observe and watch others, ask questions where you feel bad, and continue to study. And then intermittently, at least twice in a month, in between, try to present minimum. In the last 6 months are the most intensive. I would say one case, short case and a long case every week, and the last 3 months until 1 month prior to the examination, present every day. If faculty is not available, present to the senior resident or present to your next PG, so that they can ask questions and how you come to a diagnosis. For the day of the practical examination, just before the final day, revise the examination methods, specifically some special tests, and gather what you need so that the next morning you don't feel, I haven't got this, I haven't got that. Sleep well, because that is what will make your memory come alive, rather than if you tire your memory reading all through the night, it will be bad. And before going for the examination on the day, it will be better that you do some light exercise, because the basic heart rate would be higher, and after exercise, it goes lower. Eat your breakfast. We have seen people fainting, and be hydrated. This is very, very important. And say a prayer. God will help you. And it's important, don't forget to carry your documents, the clipboard, because on the bed, in case you are given a sheet to write, you won't be able to do that. Carry some snacks and waters. I was not fed during my DNP examination, so I didn't even carry things, because nowadays DNP gives money to feed the students and the examiners, but sometimes somebody may falter. And carry some money in your pocket naturally, and travel tickets. We had an incident when the examinee came and he had deposited the ticket with somebody, and it was the flight time, he didn't have the tickets. And don't forget to carry your confidence along. Of course, these are small things that you will remember to carry, and very important, have a look at yourself in the mirror and see. The examiner doesn't want to see that you had been studying all through the night, so you didn't have a time to take bath. Be well groomed. It's very important to be presentable, because you're going to be a consultant and you have to look like a consultant on the day of the examination. Just before you go for the examination, go and visit the bathroom. The sympathetic activity will lower down once you activate the parasympathetic system. Your heart rate will go down. Take a couple of deep breaths, just like 5 deep breaths, I would say, and try to bring a smile on your face. It helps reduce down the worries, and say that I can really do it. In the practical, we give cases. Of course, the tradition is to give 1 long case and 3 short cases. Some places have 2 short cases, some places have spot cases. So it all depends on which university you are working with. And of course, when you talk to the patient, be very respectful. And expose only what is necessary, and especially during winter season, look at their comfort, that they are not exposed unnecessarily, and look at the hygiene. I always try to see the patients, they touch the patient and they do this or do this when they talk to the examiner. Never do that. We know that you are going to be a consultant and you are already a doctor. You know what is a good hygiene. If you touch the patient and touch yourself, or you touch yourself and then touch the patient, both are bad. So try not to do that. The expectation in a short case is do the general physical. People forget to do the general physical even after telling them. It happened just a week ago that I was in an examination on Wednesday. I told, look, you have to do the general physical and the part to be examined, or the system to be examined, and they forgot, and then do this regional system. You can take just about a couple of questions, 2 or 3. Don't take history. If you start taking history, you will miss out, because you are given 10 minutes to 15 minutes for a short case. Don't, bother that you have to have a complete history. Just to make a diagnosis, 1 or 2 questions. And why did the patient come to the hospital is a key question that you have to ask, so that we can fulfill what the person is doing. We try to have an objective method of examination, so that in case you falter in one, say examination, or you falter in demonstrating a sign, or you falter in making a diagnosis, or you are not able to elicit a proper differential diagnosis, you are not failed only because of that. we respect the examiners, but at the same time also expect the examiners to ask questions, because the National Medical Commission as well as the National Board of Examination, they want objectivity in assessing the patient. And I like to show you a few examples when the general physical examination is mixed. The patient was given a case last week for a foot, examining the foot. The patient naturally had a foot drop. This fellow didn't do a general examination, and he said it's a common peroneal nerve palsy, and it happened to be a case of hemiplegia. He hadn't looked up or the upper extremity. In an amputee, we asked for the stump description, and person was blind, which changes the whole scenario in training, and the person didn't look at the eye examination, general physical. It's very important to do a general physical. Remember this. The common questions in the short case, like you are presenting, we have 8 patients to be seen, 8 examinees to be examined on that day, and we are in a very big rush. We say, what are the positive findings in the general physical? Or what are the positive findings in the systemic examination? And in case you get an amputee, whether the stump is good or bad. So master those things. Summarize what is important to be told. And in the long case, we have this kind of marking system so that you are examined wholly. And this is from Bradham, how to examine a patient, how to take history, and what are the points in history. Just go through, don't try to read this. The tips on presentation are important, that keep telling the history. When I am presenting to the examiner, I will keep on speaking, I will not stop for the examiner. Oh, haven't you told me this? You forgot about this? No, sir, I am coming to that. It shouldn't happen. You should carry on speaking till the examiner stops you. Stop. Because we get deeply impressed in case a student is bubbling with the history, examination findings, differential diagnosis. We like it very much. Don't stop, but don't blabber. Don't give, shitty stuff. I'm sorry to say that, but it's important. And also, in case you have stopped, given the differential diagnosis, don't look at the examiner's eye and ask what. Let the examiner be baffled with your presentation, and this is the patient, this is the differential diagnosis, this is my final diagnosis, this is the problem list, and my plan is like this, short term and long term. So go like that. And when a question is asked, like how would you manage spasticity, don't simply say I will put baclofen pump. Don't simply say that I'll do this. Be systematic, be step by step, first line, second line, third line, and ultimate. Don't simply go to the interventions as the very first thing, which is normally happening these days. You get a patient with shoulder pain, you say I'll inject a steroid. That is not the first thing. The common misses that we see in most of the patient is that they forget to ask in the history after the initial status whether there was an improvement or a deterioration, and what happened after treatment, what happened after surgery, and over a period of time. And most commonly, these are the important things which are commonly missed by the students in the final. Of course, anybody can miss anything, but in case you happen to remember this, sexuality, people are scared to ask because they are not comfortable with their own sexuality. Hobbies and interests help the patient in coming on to getting a vocational goal. And when we do a spinal cord injury examination, we forget cranial nerves can also be damaged because of the associated head injury. Deformities and contractures, people forget to mention as a separate entity because that has to be enlisted as one of the big problems. And people even try to, forget to look at the pressure ulcers or other trophic changes which might be occurring in addition. Summarize the case. I like a couple of students who were presenting their national board examination, and they came over after the history, they gave a summary of the history, so that in case examiner is wondering whether my bills have been settled or not, and whether I have this coffee is cold or it doesn't have sugar, and things like, so that they remember that okay, this was a case. After doing the general physical, tell the positive findings so that the examiner knows. So that the examiner knows what you are talking about. It tells your acumen, at the same time reminds the absent-minded examiner also or in case he's occupied elsewhere. So summarize after everything and try to write a summary of 4 to 5 lines only. Don't repeat a full page history in the summary of the case. Practice. If you practice to write in 4 or 5 lines, maximum 6 lines, you will excel in the examination. And when you talk about the sensory, don't give details. Make a chart that is written in the book also. And when demonstrating sign, don't explain it to the examiner, I am going to do this, because the examiner is watching you. But explain to the patient what you are going to do. People in UK are failed because of not telling the patient or taking consent. Do appropriate positioning in case you are asked to do a muscle power examination. And then just tell the examiner what findings that you had or what was the interpretation of the test. In case the examiner asks you about the details, only then talk about the details. In differential diagnosis, just enumerate everything. Talk about 2 or 3 salient points. Like in case this is the thing, it is not because he doesn't have this doesn't look like this. And this is a possible diagnosis, I would like to do this investigation to confirm it. So that is a way you will carry on. And people don't read, but it is very important to read differential diagnosis. I have been following the French book of differential diagnosis. It opens your eyes to think, because if you read the book, it has so many chapters, so many systems, and once you have the book on differential diagnosis, you can try to make a differential diagnosis. Instead of 4 or 5, you can make 30 or 40. Like for an example, if you have a foot drop case, so you have the nerve, the spinal cord, brain, muscle, bone, joint, soft tissue, anything. And out of that, how many things can happen to the individual tissue or individual thing that can cause foot drop? So in foot drop, I saw there were about 38 causes listed. In diagnosis and investigations, after you have a presumptive diagnosis, say what is the investigation required to confirm the diagnosis and the differential diagnosis, and what are the risks and complications for that. And I'm going to say for the intervention or the complications which can occur because of the primary condition. And in case you are giving drugs, say in rheumatoid arthritis, what is the monitoring line? How many days after you would like to do the investigation and why? Because you have to understand the toxicity also and the side effects also. When you order the investigation, say you will do the ultrasonic examination, MRI and CT, anybody can write what you are looking for in that. That is important for the examiner to know. I will do an ultrasound examination which might show this in this particular diagnosis and not in that particular differential diagnosis. So that is how you have to tell what is to be expected out of the investigation. If I say, I will do CBC, I will do ESR, I will say hemoglobin is expected to be low and the TLC is expected to be high and ESR is expected to be high and CRP so and so and like that. And after you have finished writing, talk about the problem listing. Don't simply say in case a patient with spinal cord injury comes unable to stand, unable to walk, this, that. That is okay, that is a problem, but look at what the patient is wanting. And go into the history, social, functional, psychological, vocational, sexual, and what are those areas. Like if you remember the definition of rehabilitation, physical, mental, social and vocational aspects, and list the problems all into that. Put yourself into the shoes of the patients and imagine what would be wrong. And after you have done the problem listing, it's very easy. You know a problem, you know the solution. The problem is you don't know the problem. So you have to dig the problem out and look at what is immediately to be done, what is to be done in the long term. And the favorite question of the examiners is, at the end of your intervention, what will you tell that the patient will gain? He has come in this way. After rehab intervention of n number of days, what is the expected outcome and ultimate life goal? So remember that you have to imagine for that patient. And never say that in case you get a patient, say 1 year after the spinal cord injury, don't talk about the initial thing. Look at what is required today. What is the problem of the patient today? Work according to that. And in case a question is asked, many times it happens that you don't know about it. Admit that, I'm sorry, I don't recollect that. It's okay, because we all are human, and with the stress and with many other issues, or even the functioning of the brain, we may forget things. So don't ever make wild guesses or tell anything that you don't really are sure about. And in case examiner says, what will you do in case a patient comes to you in the OPD tomorrow? You say, of course I will call the patient again, or in case I have somebody to ask, I will consult that person. But you won't have that person after you have done their MD. For the Viva Voce, prosthetics and orthotics, where people don't have the facility, they generally haven't seen the checkout, read about it or go to a facility and learn. People are very open to have the students from other institutions. Surgical instruments, where if you are not doing the surgery, then it again becomes a problem. At least you have done it during MBBS, you have read it, what is the thing to be done, and read about it when you are say preparing how to do an amputation. You read Campbell or you read other books on orthopedics and surgical things. And what are the drugs which are used? Botulinum toxin, phenol, steroid, all this is written. What is the dose which is used, and what are the methods which are given? And keep on practicing the X-rays, ultrasound, EMG charts and things like, so that you don't have to cut a sorry figure in the examination. A few pathological favorite specimens are also given, so go about that. And I believe that once you are in a department, you have visited the whole of the department, all the instruments, because you are the prescriber, you are the coordinator. You ought to know about what is the physiotherapy and the occupational therapy equipment which are used and why they are used and where they are indicated. Additionally, in the Viva Voce, in case you have done something wrong in the theory, the examiners would have most probably examined your answer sheet on that particular day. In case you have missed out an important thing, after you finish your theory, read about it, because it's very likely that the examiner will ask you those questions, whether you really know or you committed a mistake there, and that will also change the outlook of the examiner, that yes, if you faltered, you are trying to correct yourself. And these days the thesis Viva at many universities are being held on the day. So read about your thesis, the number of cases, what is the outcome, what was the methodology used and the statistical methods used. So that is again part of the Viva in some universities. Previously thesis used to be evaluated separately. Now NMC have to, some universities say that it is to be asked in the Viva Voce examination. It's very natural that when you are there in the examination, when you are sitting, when you are standing, when you are having a very pumping heart and you are not very certain what case you would get and what would the examiner say. In case you have practiced presenting cases, you have studied, there's no reason to worry that the exam is nothing different than what you would be doing in your OPD or in the ward. And you had done that for the last 3 years or maybe more. So always imagine that you are in the ward and you have to examine a patient that you would do in your OPD, which you have got accustomed. I say that in 6 months into rehabilitation, you are accustomed to treat most of the patients coming to PMR and practice the presentation of all sorts of cases. In case you have done that, there is nothing to be worried about. I remember my first year PG, we had an examination 6 months after that, and we put them to do the timekeeping for the examination which was being conducted for the 3rd year. And the first year PG after the end of the examination said, "Sir, we've been watching the questions that we were asked during the case presentation. These are the same questions asked in the examination. So you know the answers, you know the questions. So in case you keep on presenting." So it is very important that you keep on presenting. There are very few cases which are kept in the examination. Of course, this is not a comprehensive list. You know what is coming to the OPD, and when you go for the examination, these are the questions which patients which are kept in the examination. And once you have finished your exam, recollect what went wrong, theory as well as practical, and read about it where you faltered. You will remember that thing for the rest of your life, I'm sure. In case you faltered in the examination, And I would always say, exam is not the end of the story. You continue to read even after you retire. I remember Dr. Verma, he would read the journals even 20 years after retirement. He would know about the latest books. He will come and discuss with you the differentials in case. That was the awe that we had from our teachers. So continue to have that kind of an awe. Thank you very much. I'm open for discussion in case anybody has any question. Thank you.
Any questions, any comments?
Thank you. Sir, at few places they have added in the marks distribution along with thesis the micro teaching methods that we as an examiner used to ask. Can you comment over that or tell something about the micro teaching to our PGs? At few centers I have seen they have added 10 to 15 marks to the micro teaching. PG are being asked about the micro teaching while presenting their thesis.
Why don't you tell what is it?
Yeah, actually it is a teaching methods. Actually, as we all are engaged in this teaching, so at few centers I have seen examiners are being asked to the examinee. So it's just about the teaching. You all know you are taking classes for your junior residents and your even MBBS student if you have done it. So it's a teaching methods in a smaller group of people like 5 or 7 or 10 people. And you introduce yourself, you introduce the title of the talk, and you do the demonstration, illustration, and explanation in your methods or your ways. This is actually some places I have seen. Actually, I have asked also because it's in their marking tabulation. So this is all in summary, in a nutshell, about the micro teaching that you have to learn while facing the exam. That's all from my side, sir.
Yeah, thank you so much, Dr. Pandey. Actually, to be a teacher, to be a specialist, is teaching, research, and patient care. All three are involved. And I remember my elder brother, when he went over to appear for an interview for becoming a teacher in a school, he said that, okay, this is the interview board, imagine this is your class, and start teaching this subject. And he immediately stood up, he said, "Bachcho," he said, stop, this is good enough, so you can teach. So always imagine yourself to be in that situation, that play the role of what you have to be, what you have to do.
Thank you. Any other questions, comments? Yeah.
So, in problem areas, is it necessary to explain according to ICF structure? Body structure and function activity limitation?
It is dependent on what is the case and what is the condition and what is the scenario. You can imagine any way, in any case, but always imagine that you are in the shoes of the patient and you are a doctor and what complications you are expecting. Talk about those. It is not necessary that you follow a particular system. Just imagine that you are in the patient's shoes and what will happen to you.
Okay, sir. Thank you.
Thank you. I still remember the PMR exam, the NB exam, where using Kothari, Verma, and Shanmugam as my examiners, and George Sag also was there on that day. Thank you, Professor Yusing. I would like to invite Dr. Rajiv Thomas to present a memento to Professor Yusing.